This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details. This episode is sponsored by the International Critical Care Paramedic Group. So the ICCPG unites regions worldwide to enhance paramedicine through global knowledge sharing and improved communication amongst critical care paramedics. So following the success of their inaugural 2022 conference, which gathered over 600 paramedics from across the globe, the ICCPG is thrilled to announce their second conference on January 30th, 2025. So the first event, hosted by the UK College of Paramedics, featured speakers from the UK, Australia, New Zealand, Canada and South America, discussing the vital role and unique challenges of paramedics in their regions. So the 2025 conference aims to bring together paramedic professionals worldwide, exploring topics including case studies, followed by in-depth discussions on clinical training, leadership or research aspects. So don't miss this chance to connect with peers, learn from international experts and advance global paramedicine. So mark it in your calendars for the 30th of January 2025 and stay tuned for more details about this online event. For more information, please head over to the show notes.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, I'm speaking with Samuel Bulford around life as a Sydney HEMS Registrar. So what I wanted to do in the episode is really examine and explore the anatomy of work that Sydney HEMS Registrars see within their time at one of the most progressive and indeed dynamic air ambulances in the Southern Hemisphere. So what we're going to do is dig into the day-to-day life, the clinical governance, the case mix, and indeed the debrief that occurs within Sydney HEMS teams. We're also going to examine some of the most significant challenges that our guest has experienced as part of that team, and indeed the team that's striving to improve and foster innovation and deliver safer patient care. So to do this, I have Sam Bulford with me. Sam is a Sydney HEMS Registrar and indeed the host of the Sydney HEMS Debrief podcast. Welcome, Sam, to the podcast.
Thank you very much for having me on.
It's great to have you with us, Sam. I just wondered if we could kick off with just walking us through a typical day as a HEMS registrar in Sydney. What's some of the sort of case mix that you typically encounter as part of that day?
Certainly. Well, as we go through this episode, I'll just say at the top that this is certainly from my experience, and I'm not talking on behalf of the organisation, but it's a really fascinating service to be a part of. I feel very lucky to be a part of it. To put that question into context, I mean, New South Wales is a huge state. As I'm sure you know, on the east side of Australia, you can fit the United Kingdom into New South Wales about 4 times over, and that's really the kind of geography that a daily case mix might involve. We have a mixture of rotary wing assets, fixed wing assets dotted around the state, as well as conventional road ambulances as well. And any shift will be on a combination or one of those, of course, as you imagine, spread across the 24/7 roster. We do a mixture of primary and secondary work, noting, of course, that within New South Wales, you have very urban areas, and there are vast areas of land which do not have consistent or high-level medical provision. And it is often those secondary transfers which are the most kind of interesting and the most challenging. We see adults and children, although there is a dedicated secondary pediatric transfer service, but they are very busy, and we often do a lot of the secondary work for kids as well. So with that in mind, As a Sydney HEMS registrar, you will start your day shift at about 7 a.m. You'll come in, we call it the boarding zone or the departure gate, and you'll have a cup of coffee. You'll meet the team for the day. You'll introduce yourself to the critical care paramedic, even with whom you'll be working, and the pilots. And you'll do some admin on the computer just to give the pilot a fatigue score, which will help decide the types of missions that you can undertake that day. Pretty early into that first hour of your shift, you and the critical care paramedic will do some equipment checks, both of the equipment you'll be taking onto the asset on which you'll be working, as well as some checks of the aircraft or the vehicle itself. At 8 o'clock in the morning or in the evening, we do a whole team brief, which is led by the duty pilot of the day. And that is a really valuable moment where, as a whole team, we can come together and we can ascertain the risk of the kind of missions that we might be encountering during that next shift. That will include weather, fatigue scores, any aviation specific risks, such as no-fly zones, which might prohibit a particular transfer. And from there, we go into some base activities. During the day, of course, the night shift get to put their feet up a little bit. During the day, then, we will go through more equipment checks, and we'll do some pack checks, making sure that all of our equipment is in date and serviceable. We'll do some currencies, which will include an airway currency. It might include a winch currency as well. And it will include just doing some simulations, often on a semi-formal basis, just to make sure that we're current and that we're prepared for what we might encounter during that day. At 10 a.m. every day, we do a coffee and cases, which is a really valuable and unique part of the day, which I hope we'll talk about a bit more later. This is where, in a very informal environment, the duty medical team of the day will talk about complex missions or cases that they've encountered over the previous shifts in a non-judgmental, open forum where we can talk about what went well, what we'd like to do differently next time. And it really fosters that sense of openness and collaboration that again, I hope we'll touch on later. We then got about up to 11 a.m. on a day shift, and we then wait for the taskings if they haven't already happened, of course, since we arrived. Now, those taskings, like I say, will be primary or secondary work, but a really key aspect and a really unique aspect of the Sydney HEMS primary work are the rescue missions. So our Augusta Wetland 139 aircraft are equipped with winches. We are all winch trained, and our missions therefore can include some extrication work from the many canyons and caves that we've got around New South Wales, the many cliff faces, or the winches can be used by the critical care paramedics who are water rescue trained as well, which is a really important, valuable, and in some a very busy part of the workload. The critical care paramedics have an exceptional skill, and in addition to the rescues that I've just mentioned, they, and to some extent the doctors, are also trained in bush rescue and overnight bush missions as well. So you can therefore imagine that when you turn up at 7 a.m. every day, there's this huge state into which you could be sent to do really any kind of work you can imagine. It's absolutely fascinating. And you know, after every mission, you'll do your paperwork, you'll debrief, you'll get your equipment ready, and then you'll get ready for the next one. So that's what a typical day looks like. We do maybe 1 to 2 kind of missions per shift. And largely we stick on the same asset that we started on, although there is a bit of flexibility and depending on the workload of that day.
Yeah, Sam, to your point, there is really a heterogeneous case mix. And so, like you said, you are not only the critical care assets, you're the search and rescue assets, you're the winch assets, you're the overwater asset. There's and I think to that point, that mandates and requires multiple mission profiles and multiple competencies, which again, it makes the case mix and indeed the case debrief interesting and the coffee and cake interesting, but it also mandates true competency. And so, that mandates training over multiple different missions, which is challenging because I think in other services, there isn't necessarily that heterogeneous case mix. So you're not necessarily winching in every different HEMS service. They're not necessarily going over water in every different HEMS service. So there really is that different challenging case mix. But could you maybe speak to that actually, Sam, if that's okay? Because with that comes unique challenges, and indeed, there's a critical care patient on the end of that case. But the extra challenges, it could be across water, could be in the bush, could be a search and rescue mission. Could you maybe speak to some of those specific challenges?
You're certainly right that the environment alone often poses a challenge. And in the state of New South Wales, you can go from the snowy mountains with your knees deep in the snow one moment, and you can be by the beach the next. And so, yes, you're right. How does one adapt to those environmental challenges? Well, we do it through a combination of we have a lot of very specific equipment depending on the type of environment we're going into. This will include, of course, the bush, into which we have been placed occasionally overnight. But more so than the actual physical equipment is the training that you do that prepares you for that. So we have a very thorough at least 4-week induction period as a registrar, during which we will do a combination of clinical um, scenarios, and there is a test at the end to make sure that we are competent to function on the aircraft or on the back of the ambulance. But there's also 2 dedicated weeks of aviation training, which will include, like you say, things like winching, how to prepare the cabin for a water extrication. Um, Now that's all well and good for, the first month that you're doing it, but how we maintain those currencies is that we are obliged every few weeks to do what we call a static, and that will be a static winch assembly. It'll be a static stretcher winch in the hangar, and it'll be a talk through with the critical care paramedic about how we would, for example, prepare ourselves for the overnight, for the multiple casualty case, for the water rescue. So it's that kind of continuous immersive kind of simulation and training that we do. That said, whilst the primaries do include austere environments, there's also the perhaps more bread and butter primary work, which will include the trauma, penetrating blunt. We have increasing penetrating trauma in Sydney at the moment. And that is as challenging as anywhere else. Um, the 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 secondary work is, I think, something which makes Sydney HEMS really unique. And I will say that in my experience, the secondary transfers have actually been the most challenging, because that's where you have a bit more time to think about the nuances of the medicine that you're practicing. And you've also got often a lot more time until you reach the destination. So you have to both kind of think independently fairly quickly, but gathering all the information from that case to date, put this patient into a tiny little cabin in the back of an aircraft, and then fly them for sometimes hours at a time, anticipating all the potential deteriorations or problems that you might encounter. So the primary work is absolutely challenging because of the environment, because of the hyper acuity often of the patients. But the secondary work, given the geography and the hospital setup and landscape of New South Wales, is, I think, sometimes the more challenging.
Sam, absolutely. And to your point around actually information entropy can be a massive factor within that intra-team kind of dynamic where there's a handover of information, complex information, and the information entropy is any key aspects of, are they on pressors? Are they on how much blood have they had? What is the initial primary survey? What's the secondary survey? But in a sequential fashion, making sure that you've captured everything that is necessary. And also, to your point, Sam, up in the air, this was certainly the same in British Columbia, 1 million square kilometers as a province. a critical care patient, you've got a 4 hour transfer or 3.5 hour transfer, an hour and a half in, and they become critically unwell and unstable. Do you deviate? Do you land? Do you continue? You just run out of blood. What are the options? And actually, to your point, they can be extremely challenging patients. And with that extended time in the air, there's a whole different sequelae of problems which can come to fruition. So, Sam, to that point, and the question on the end of that statement would be, could you maybe speak to a challenging case? Because there's you could probably take 1 million from your time at Sydney HEMS, but could you maybe just unpack for listeners a semblance of a challenging case, just to give them a flavour of some of the things you've interacted with?
Certainly. And in every challenging case, myself and my colleagues have always been next to one of the critical care paramedics. And just to detour briefly, the CCPs at Sydney HEMS are top shelf. They are absolutely the best in the game in anyone's estimation. They have come through the ambulance service ranks to the point that they have proven themselves time and time again through the training to get the job and the continued training that they do, to be the most incredibly skilled operators in this business. And so every challenging case that I or anyone else will describe must always be framed in the context of being next to, at that point in your day, possibly even in your career to date, next to your best friend in the world. So, and I want to pay absolute tribute to the CCPs to start off with. A particularly challenging case from my perspective is one which includes very dire patient pathology in combination with a system which needed to be orchestrated to create good care for this patient, and a system which actually did that, and the patient had a terrific outcome. So this particular individual was at a regional hospital. It was around say a couple of hours flight from Sydney. They were fairly young, no real other medical problems, and they presented to this facility with a chest infection. This facility has some incredibly skilled staff, like in most rural facilities in New South Wales, a combination of very senior nurses and GPs who have their hand in, a bit of anesthetics, a bit of obs and gynae. They're real rural generalists, as we call them here. And this patient arrived at the facility in pretty dire straits. They were hypoxic to the 60s. They were tachypneic up to the high 40s. They were febrile, hypotensive. They looked rotten. And what was clear from the history that was being gathered was that they'd become sick really within 24 hours, and they were therefore on a pretty quick downward spiral. So I was activated as part of a helicopter team that day, and myself and the CCP and the aircrew, we flew down, and we arrived at the hospital to find that the hospital had already done something which is really great in New South Wales and unique in New South Wales, which is something called a SIRS assist. Now, this is a function whereby a rural health provider can effectively dial 000 and ask for senior paramedics in the area to come to that facility to help out, because that provider recognized that the patient's needs outstretched what that facility could currently provide. So there was already a wonderful team there, which included a couple of rural generalists for nursing staff, and then these senior New South Wales paramedics as well. They'd done some wonderful things. They started the patient on some respiratory support. They'd started them on some peripheral vasopressors, but nevertheless, this individual was still deteriorating, and was deteriorating both clinically and biochemically on the small amount of blood work we could do locally, very quickly. So we have a workflow whereby myself and the CCP, we kind of break off. The CCP applies our equipment and our monitoring. I do my assessment and I make a bit of a clinical plan, and then we come back together and we kind of update and do a couple of minutes chat as to where we're both up to and where our priorities were. And it was quite clear that the destination that we had been allocated for this patient, which was a bigger hospital, but still a rural facility up the road, it was not right for this patient. And because I thought this patient needed ECMO, and I thought they needed it pretty quick. So in order to make that happen, we phoned the Aeromedical Control Center, which is the dispatch it's the dispatching team and service, I guess, for New South Wales aeromedical retrieval assets. But it's also got some individuals in there that can start to get the process going to, for example, activate a hospital ECMO team, to get an intensivist on the phone, to get more resources to scene if needed. So that individual, the state retrieval consultant, as they're called, supported by the team of senior paramedics and nurses in the room, were already alerted from our own early phone call that this patient needed quaternary level care very quickly. Our best option was to get this patient up to Sydney. Myself and the CCP, we intubated this gentleman. It was a particularly challenging intubation physiologically, and we needed to resuscitate the patient before and afterwards, as you can imagine. And he then, the CCP, that is, kind of made the point that, we've also got these aircrew considerations. So we had fatigue scores with the aircrew. There was some weather moving in. And so time was really kind of pushing up against us. That said, in concert with the team that were on site, we were able to place some more lines. We started some additional medications. We did some ventilator troubleshooting. We were in conference every so often with the Quaternary Hospital in Sydney, who were activating their services, their side, and calling the necessary people in, etc. And we also got the air crew to get the aircraft ready. We were then able, therefore, to load this patient pretty efficiently up to Sydney. We got some air traffic control bypasses, and we landed pretty hard landing on the pad of the big hospital up in Sydney. And we rolled into the intensive care unit where the ECMO team were already scrubbed and ready to go. And before I'd even taken my gloves off and started my paperwork, this patient was being put onto ECMO. It was a really challenging job because not only was the physiology very difficult, and it was clearly rapidly evolving in a rural facility that did not have all of the luxuries of a tertiary emergency department or resus room, but to kind of get that process going required an awful lot of work and decisive action from the CCP, the aircrew, and the control center as well. That said, the system did work, and this patient walked out of hospital pretty much the same way that they were walking a week earlier, after about 5 days worth of treatment. And I think it just goes to show how these really complex patients, far, far away, in concert with the system that works, can have really good outcomes. And I was really proud and happy to be a part of that really challenging case.
Listen, Sam, that's fantastic. From a number of reasons, like you said, there's multiple moving points. There's dynamics which are at play in that case, which are really interesting. Like you said, weather, fatigue scores, patient's physiology, multiple communication points, making decisions across the spectrum. So, like you said, communicating with the team, the ECMO team in Sydney, also with the operations centre, communicating with the rural team on the ground, and but most fundamentally and importantly, communicating between you and the CCP. So, like you said, putting a plan in place, working out the feasibility of that plan, and then speaking with the pilots. But I think just what that case orchestrates and illustrates is really the dynamic nature of pre-hospital care. There's so many junctures of decision making, communication points to get the system running and indeed at play. But like you said, it absolutely works, and when it works really well. And to a point, I spoke to Brian Burns last week, And he was saying, we're starting to see in New South Wales survivors which you would never see actually fundamentally in the past because the system is working, because there is a pre-brief, because the ECMO team is scrubbed and ready, because there is such good briefing, systematic, sequential, chronological briefing to the operations center. That's then being pulled through to the ECMO team. But because the system's working well, you're seeing these fringe survivors, which are now mainstream survivors, and actually that is testimony to a system which is adapted, which is continually improving, and which is striving to convert these fringe survivors into mainstream survivors, so that actually you're getting a whole different card array of survivability across the spectrum and across pathologies as well, which is testimony to the team and testimony to you on and the team on that day as well, Sam. And so, bringing this into clinical governance perspective is my next question. You clearly, clinical governance is a fundamental part of of a high performing team and is part of Sydney HEMS. Could you maybe speak to you did speak to, at 11 a.m. you sit down, or indeed 10 a.m. you sit down, you have cases in coffee or cases in cake, and you start to dissect these cases. Could you maybe just really unpack the your learning journey that you've learned through clinical governance and through dissecting these cases?
I think the approach to clinical governance for the organization is absolutely unique, and one which I have not experienced in hospital to date. And I'm sure many people who have worked for pre-hospital organizations have said that it is a very different approach to governance outside of a hospital to in. I think for me, from my experience, it really comes down to this open culture. And it's very easy to talk about having an open culture and to write down that we have an open culture, but I've really felt it in so much as clinical governance is taken very seriously. Quality assurance is taken very seriously. You've alluded to the 1%ers. We're always trying to strive to kind of satisfy that 1% and get better every time. But it's done in a way which means that anyone can participate in that we can learn from things that didn't go so well, that we can feel comfortable to be vulnerable and to share what we perceive as things we could have done better. And if the whole organization is doing that in a non-punitive way, and that permeates all the way from the top, that's how good clinical governance is delivered. Well, I suppose that's the culture of it. I mean, in terms of the tools through which it's delivered, coffee and cases is a great example of the informal ones, and it does happen 7 days a week. We're invited to dial in from home if we're interested. It's really valuable. Other tools through which it's delivered will be at our monthly clinical governance days, where challenging cases are discussed. Of course, we've got M&M as well. We've also got a physician on the team who's solely kind of dedicated to airway audit. We pride ourselves on having, I think it's something like a 98% first pass success rate of all comers, regardless of primary, secondary, or age, which is pretty astounding. But, picking up on the cases where we didn't get the tube in the first time, where there was a desaturation, and talking about it, not naming names or criticizing, but just talking about what other people would do, so that we've all got this recipe book of things that we could do differently next time. We'd also celebrate the good things as much as we talk about things that, M&M. So we have the awesome and amazing, which is where one's cases or actions are nominated either anonymously or with a name, and they're celebrated at these monthly clinical governance days, so that we can continue to do what we do well, even better. The final thing as well is that for every single patient that the service encounters, we get feedback from the hospital. So as part of our daily activities, which I suppose I neglected to mention earlier, the clinicians on duty that day will ring the hospital to which the patient from the previous day had been transported to get feedback on how the patient had progressed over that first 24 hours. Because it just means that, we can establish whether or not our treatment was timely enough, adequate. But again, to celebrate the fact that by, for example, providing that secondary neuroprotection, the patient is already, starting to wake up, for example. So that kind of feedback is another very useful tool through which I think the organization and the individuals really embody that open culture of striving to improve.
Sam, that's fantastic. Like you said, this semblance of feedback of outcome is really important, actually, because I think you're right. You can course correct future treatments and actually give that feedback, that necessary feedback of was the intervention right? Was the ceiling of care correct? And it is absolutely essential. One other aspect, and you base the Sydney HEMS Debrief podcast on this. It's fundamentally called the Sydney HEMS Debrief podcast. Debriefing is such an important aspect of the whole picture. Could you maybe speak to, because the coffee and case is really archetypally the cold debrief. It's we can really dissect down into the details, but the hot debrief is also fundamental and important. Could you maybe speak to the hot debrief and the debriefing that comes after the case, and what you can learn and what indeed you have learned from that?
I think it happens in different ways for depending on the job. The most valuable hot debrief, I think, is the one with your CCP. Like I say, these individuals have been around for many, many more years than any registrar and many of the consultants. They have seen everything before, and they are kind and supportive and generous, and they listen. And I think that in kind of combination with the air crew who have also been a part of the case, somewhat vicariously sometimes, but that's also a valuable point to debrief. I think with your core team is the first port of call. And that can be really helpful to get out those immediate feelings, the sitting on top of your chest feelings. In addition to that core team, there's always 24 hours a day a duty retrieval consultant who is a senior consultant who is always at the end of the phone for clinical advice during a case, or to have those debrief moments afterwards. And they are, profoundly kind and valuable in having those conversations, and they're very good at having them. Um, in addition, and again, I think this speaks to the kind of culture that has been developed much before my time, of course, and I'm not taking credit for any of this, but we have a significant events registry, which is a database of cases into which anyone can put a case, which then flags the individuals who were involved in that case with members of the broader team who have had specific training in significant event counseling or debriefing. Now, these are paramedics, doctors, administrative staff, and you might find that if you have been involved in a big case, a few days later, one of these individuals will shoot you a text or ring you up and just see how you're going, invite you out for a coffee, that kind of thing, which I think is really nice and really valuable because it's someone who you can talk to in confidence and you can just thrash out those feelings, which, unlike the ones from the hot debrief, have maybe been mulling over a little bit as well. So I think those are the kind of layers of debriefing, but all of these sit within that open culture that we've described. And I think the combination of those two are very powerful. And I think it certainly helps us to achieve those 1%ers to kind of continue to be kind of excellent and emotionally competent physicians and to get ready for the next job.
Absolutely, Sam. And to your point, it all just lead back to culture, and good and bad culture is felt definitely at service provision level. And So you spoke to something really interesting there about, I think, the psychological ramifications of an incident. Like you said, aren't necessarily resolved in a hot debrief. They're first interacted with sometimes. You first interact with your feelings, but it does take time for those to come out. And so that longevity, but that capture of those psychological feelings or indeed processing those is it's good to see there's a system in play to sort of capture that and flag that and sort of dissect that. I guess my next question, Sam, really is what you've taken from your time within pre-hospital care. Because as you said before, it's a fundamental shift from in hospital care, both from a cultural perspective, but also from an adaptive and flexible approach perspective. Could you maybe speak to how you've adapted your approach from being sort of an in-hospital doctor to a pre-hospital doctor?
Certainly. So I guess one can adapt their approach to training, kind of the before, then the during the job, and then the after. So I guess my time with Sydney has, and I've done all of my training within the Australian system. So I've got a fair comparison having trained at hospitals just down the road from the base. We do an awful lot of currency practice on a daily basis. And it might be an airway drill that you've done 100 times before, but each time it's really good rehearsal, and there'll always be interesting discussion points about what we can do differently to improve. So I think that in combination with the very thorough, dedicated induction training, I kind of approach to training and moving into the next step of my career where I will be delivering training for trainees as opposed to being the one being trained, although I guess it never stops. I hope that I would work in a system which has the time and the facilities and the wherewithal in order to provide that continuous growth and learning before an event happens. I think that on a job itself, we talk a lot about forward momentum, and we all know that moment in a hospital resus where, for example, the patient gets ROSC, or for example, the pneumothorax has been decompressed, and everyone kind of sighs relief, and then a few people leave, and you as the team leader or as the physician in charge, we kind of go, well, there's actually still a lot of work to do here. We've still got a list of 10 other things we need to do, and we need to do them pretty quickly. So I think this idea of maintaining forward momentum and keeping people on the same journey and managing people's clinical expectations, I think is one that I've certainly improved on. Um, and we can talk about communication strategies if you like, but it's more that sense of maintaining a sense of purpose and a direction, which is so important. As we all know in the pre-hospital environment, I think from a very personal level, I can I'm quite British by heritage, and I'll always use 20 words when I could use five. I think my economy of language has improved, although maybe not evident in this podcast. And I think that, learning how to be directive without feeling as though you're being rude. Like I don't think I've ever really been rude in my career, but I've always felt that I am. And so I think having a bit more practice and confidence in knowing how to carry oneself and continuing to be directive and the leader when you need to be without feeling embarrassed about it, I think something which I've really developed here. As for the after the job approach, it's what we talked about, isn't it? It's having those systems in place and the right personalities in place in order to make sure that a team feels supported immediately afterwards, sometime afterwards, and that there is a system and a culture within the organization which marries with that. So I hope that explains how I think I've adapted kind of my approach to the before, during, and afterwards, because I think I've sincerely learned a lot, and I know that I speak to my colleagues and my peers who feel the same.
No, absolutely, Sam. And to your point around conciseness of information, conciseness of a plan, and verbalizing that plan. And like you said earlier, you mentioned something which is absolutely key in the pre-hospital environment, which is the dynamic nature of the environment, and that just can be unseen, the noise unseen. And actually, you're in a road traffic collision, or this you've been the Bondi Junction stabbing. There's malaise, absolute malaise, and having a semblance of a quick, concise plan that the whole team are on board with, getting read receipts, so closed loop communication, and then enacting that quickly is absolutely a precise skill which needs to be honed in the hospital environment. But also, you said something there which is really interesting about um, competence of training in deeply into your subconscious mindset, because there's this such a vast array of patients which can present in the pre-hospital environment, all of which are unfasted, all of which are you don't get a pre-assessment pre airway assessment on, and all of which have is a spectrum of pathology which you may be comfortable or indeed uncomfortable with, pediatrics and adults. So you're not in a specialism, you it's undifferentiated, and actually that mandates robust training, that mandates pretty hellish training actually, because you've got environmental factors, you've got patient factors, you have team factors, you've got impinging noise. So all these factors at play mandate really strong training, which again you notion towards. So, Sam, could you speak to team dynamics and indeed just teamwork fundamentally, how you get a semblance of teamwork where there might be differing opinions or indeed aligned opinions, but how do you bring that to fruition quite quickly?
So from a Dr. CCP perspective, we talk a lot about the elastic band approach, and I mentioned it earlier, where we have a workflow that we train to, and that will depend on the scenario, but largely involves the doctor doing a brief history, an A to E assessment, performing some life-saving interventions, in that immediate 30 seconds, whilst the paramedic deals with the scene, the environment, and then monitoring. We then come back together and we share those priorities, and we do that in a very succinct way. We often give a timestamp, and then this is communicated this is in the case of a primary, of course, to the many individuals around us. And I mention the word many, noting that within New South Wales, there are many different agencies that we will encounter dependent on the jurisdiction, the job, um, and or even the time of year. Some of them change. So teamwork's really important for the CCP and the doctor, and we get quite good at it because we practice so often. But teamwork for the rest of the um, clinicians involved in the patient care really kind of is going to be led by what they see from us. And, it's going to be led by the plan that we give and the communication that we give. Also, we will be, to some extent, be led by them. For example, in the case of the fire service, telling us what we can achieve within the plan that we've described. So it's it's a model whereby we're all kind of throwing a ball one to the other, and when that person has the ball, they're speaking, we all listen in, and then together we kind of create um this model and approach, using those 30-second checkbacks, using the closed loop communication, using the timestamps that we know about. um and of course, noting as well that we do need to involve the control center, so some early updates so they can activate some in-hospital services. We have a really good service in New South Wales where we can get blood products to scene. We carry blood products on the back of the assets, but we can also request from the control center to get the equivalent of an MCP bought from the local facility wherever we are in the state to the scene. But of course, that's going to rely on clear, decisive, early communication to the control center. So it's a hard thing to define teamwork, isn't it? And people spend their whole careers talking about teamwork, but I think for me, it's been about having that kind of intimacy with the paramedic and the trust and that elastic band model in combination with that group dynamic where we throw the ball to each other and we then make a plan together, in combination with the system that's working as part of an even bigger team behind the scenes.
So, Sam, could you maybe speak to some advice you give to someone who's indeed interested in pursuing a career in HEMS?
So again, I say that I've got no say in the recruitment and I'm not involved in the recruitment into the organization in any way. But I do think that it boils down to a few key themes. And apologies if they sound very obvious. The first one is that you need to be quite good at your job, and you need to be quite good at that job because you're going to be the individual, along with the CCP, who's making really tough, quick, decisive decisions for the sickest people in the state. And this state, again, is 4 times the size of the UK. And those decisions will not be made in isolation, but they will be led by you as the clinician. And so you need to be quite good at your job. Now, we come from ED, anesthetics, or ICU, and those are the specialties really that are going to see you into a position with a pre-hospital service in Australia. The majority of people come from ED, but that's not to say that it's is exclusive or favored in any way. In combination with being good at your job, you need to be at the final stage of your training or a consultant. And your training needs to have included time at a trauma center, of course, a center which does pediatrics, and you need to have done at least a year's worth of ICU or anesthetics to have done your airway competencies. You need to have kind of demonstrated a persistent interest in the area. It's very competitive, as you can imagine. Anecdotally, it's double figures applicants compared to every job. And so you need to have really kind of demonstrated a persistent interest, which kind of shows that you get you get the memo and you understand the world a bit and you kind of understand some of the themes in pre-hospital care. And there's no one way or the other of doing that. And the final thing, I think this is perhaps the most intangible of them all, but you need to be someone that is comfortable to sit in a metal box with other people for 12 hours at a time. And you need to be that person that other people feel comfortable to sit next to for 12 hours at a time as well. And that's not something which can really be taught, but it's very important because, not only are you actually spending a lot of time in a confined space with other people, but you're doing some very strenuous, challenging, emotionally testing, academically testing activities on a daily basis. And so being someone that can have a natter, that can go to the departure lounge in the morning and have a coffee and be a part of the team is really very, very important. So I say again, I'm not involved in the recruitment, nor have I ever been. But in my opinion, being at the final stage and being a good final stage trainee or a consultant in a relevant specialty with a persistent interest and generally a nice person is how you're going to succeed.
So, looking back at your time at Sydney HEMS, because I'm mindful, Sam, that you are coming to the end of your tenure and secondment at Sydney HEMS. Could you maybe share a memorable or indeed rewarding experience from your time at Sydney HEMS?
One of the first cases that I went to was at the end of a long weekend shift, and it was to a patient who had self-harmed, and they'd self-harmed themselves pretty severely, and they were peri-arrest. And the system worked for this patient. The local crews did a fantastic job. We got there early. We got blood to the scene. The hospital was ready. And it all was over in a blink of an eye, even though I and everyone else did so much for this desperately, desperately sick individual. And you see patients, and you never think you're really going to hear from them again. But this individual reached out a few weeks later from their hospital bed and and said thank you. And they had had the worst day of their life that day, and they were still grateful to be here. And I think it really moved me, that one, because it was just a fulfilling experience in a system that worked for this person, and they're going to be forever grateful. So that's one of my absolute highlights.
Sam, that's powerful. That's powerful and really brings home, like you said, the system working, but also the semblance of every patient matters, and there's actually a backstory to every patient. So that's powerful, actually. So just as we come into land, Sam, just as a final question, really, could you maybe speak to, I guess, some take-home points, really, as to how being part of a high-performing team has actually probably fundamentally changed you, and also just how that change might sort of foster these attributes in your next role and your next mission.
So I'm moving on from Sydney, like you say. Fortunately enough, I'm going to work for an overseas retrieval service, which has not historically had doctors. I'm within their team. And so I hope that my experience in Sydney to date will inform the approach with which I take to the next service, which will be one of collaboration, of demonstrating that we can all learn from and with each other, that there is really no hierarchy. That elastic band model does not include a hierarchy of roles. And in combination with, learning through repetition, of focusing on the 1%, of championing the things that we did well, and never being complacent. I hope that I will bring some of those learnings to the next service. And changing a culture and changing one's own practice even does take time, and it's not something that that any organization or individual is ever going to be that you're never going to fully feel like you're done. But I do feel as though my time in Sydney has taught me what I want to achieve in future, and how I want to act as a clinician and the organization I want to be a part of. And so if I can bring myself to the next challenge with that in mind, I'm really optimistic, and I hope it'll help, and it will help change the culture, and it'll help me succeed.
Listen, Sam, that's fantastic, and it's just fantastic to get your reflections really on this past amount of time, how it's changed you, but also, a common thread you've mentioned throughout the whole interview is culture, and how important culture is, top down but bottom up as well, and actually patients feel that culture because it's the patients which benefit from a high performing culture as well. So it's really great to end on that. I just want to thank you for your reflections and for your time. It's been great to indeed just get your thoughts and also just journey with you through the Sydney HEMS podcast. We'll put that in the show notes because it's a fantastic podcast. The efforts and indeed interviews you've done are absolutely insightful. So we'll put that in the show notes as well. And I just want to thank you again.
That's very kind. And I encourage people to listen to the Sydney HEMS podcast with low expectations, because they will be met. So thank you very much indeed for having me on. It's been a pleasure.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.